What is your differential? Uh, okay. Look at in PCOS, there are some hormones like LH, FSH, testosterone. These are high, and in the lab they will show this type of feature. And in here, the lab shows. Look at the glucose hyperglycemia. Look at the neutrophil. There is a neutrophilia, hyperglycemia. This does not happen. PCOS can come with glucose, but PCOS cannot cause neutrophilia. And other thing like look at the stria, scattered bruises. Okay, so has several feature. This patient has several features suggesting Cushing syndrome, hypercortisolism, weight gain, proximal muscle weakness, hypertension. Weight gain, proximal muscle weakness, hypertension are common presenting findings. Patient can experience patient can experience easy bruisability, dermal atrophy, white purple stria due to catabolic effect of the cortisol on connective tissue. However, platelet function and coagulation protein and coagulation proteins are normal. Dermatological signs may include hyperpigmentation in ACTH-dependent Cushing syndrome and increased incidence of cutaneous fungal infection, tinea versicolor, onychomycosis. Women can have features of hyperandrogenism, menstrual irregularities, acne, hirsutism due to co-secretion of adrenal androgen with cortisol. Hyperglycemia is common due to peripheral Hyperglycemia is common due to peripheral insulin resistance and hypercortisolism induced gluconeogenesis. Hypokalemia and alkalosis may be present. Hypokalemia and alkalosis may be present due to partial mineralocorticoid effects of cortisol. If cortisol levels are very high, once there is lab confirmation of hypercortisolism, late night salivary cortisol assay, 24-hour urinary free cortisol treatment measurement, and overnight low dose dexamethasone suppression test. Overnight dexamethasone suppression tests. ACTH level are measured to differentiate ACTH dependent ACTH secreting pituitary tumor or ectopic ACTH from ACTH independent like adrenal adenoma causes. Yes, vitamin D, vitamin C or DEF. Okay. Vitamin C deficiency causes microvascular bleeding. Vitamin C deficiency causes microvascular bleeding due to impaired synthesis of collagen. Vitamin K deficiency causes bleeding due to reduced level of coagulation factor 2, 7, 9, 10. Von Willebrand disease is an autosomal dominant disorder. Von Willebrand disease is an autosomal dominant disorder characterized by impaired platelet function and excessive bleeding. However, none of the condition could explain the patient's weight gain, muscle weakness, hyperandrogenism, hyperglycemia, and metabolic alkalosis. In addition, vitamin C and K deficiency are not common in vegans. is low, I think. Low. Okay, first look at first primary hyperparathyroidism. In primary hyperparathyroidism, PTH is high, calcium is high. In here, PTH is low, so this is not primary hyperparathyroidism, isn't it? And in rhabdomyolysis, there may be increased CK. Creatinine would be high. Um, uh, but in here, creatinine is not that high, 1.4 maybe normal. So it's not rhabdomyolysis. Look, he has motor vehicle accident and he is in deep coma for longer period. Yes, if somebody is in a coma, uh, like for the muscle breakdown, or it happens within a days, if somebody is in immobile or immovable, if you are not like like somebody who think about in that way, somebody who is in stroke, he cannot move his body. If what we do, what we actually tell the patient to, what we actually tell the patient's attendants to do, we tell the patient's attendants to move the patient 2 hours interval. If uh, if it does not done, if it does not happen, then there is more chance of happening like pressure sore or pressure ulcer because of his immobilization, isn't it? So if he, as he is immobilized for long, so there may be muscle breakdown, so release of the calcium. So it may be uh, okay. First box, diagnosis of hypercalcemia. If you patient uh, if you patient a case of hypercalcemia, repeat testing, do calcium again and correct the albumin concentration. Like look at the corrected calcium in the calculation, the first para of the explanation. Okay, so they are talking about this corrected for albumin concentration or measured ionized calcium. So how will you diagnose the corrected calcium? In corrected calcium, we actually put the measured calcium, which is 12.1 plus zero point 0.8 into 4. 4 is the albumin label, it is the constant. 4 minus the actual albumin, 4 minus 3. So it is 12.9. So after you do the corrected calcium, it is high again. So there is hypercalcemia. There is actual hypercalcemia. after doing the corrected calcium, you have found the actual hypercalcemia. Then in the next thing you will do the measured PTH level. If PTH is high, normal, or elevated, if PTH is high, then it is primary hyperparathyroidism, familial hypocalciuric hypercalcemia, and due to lithium. So it is primary or tertiary hyperparathyroidism, familial hypocalciuric hypercalcemia, and lithium. If PTH level is suppressed, like PTH independent case, in here PTH level is low. So PTH is calcium is high, PTH is slightly low. So PTH independent, then you need to do measure parathyroid hormone related peptide 25 hydroxy vitamin D and 125 hydroxy vitamin D. We are doing this, and the cause are malignancy, vitamin D toxicity, granulomatous disease, there may be drug induced, there may be milk alkali syndrome, thyrotoxicosis, vitamin A toxicity, and the last cause is immobilization. Okay, now explanation. The patient quadriparesis has corrected calcium is 12.9 with symptomatic hypercalcemia. Like symptomatic hypercalcemia means nausea, polyuria, and symptomatic hypercalcemia is nausea, polyuria, and suppressed PTH level, likely due to immobilization. Hypercalcemia of immobilization is likely Hypercalcemia of immobilization is likely due to increased osteoclastic bone resorption. The risk is increased in patients with pre-existing high rate of bone turnover, younger individual, Paget's disease. The onset of hypercalcemia is usually around 4 weeks after immobilization. Although patients with chronic renal insufficiency develop hypercalcemia as little as 3 days. So if it is due to CKD induced hypercalcemia, it will happen within 3 days. So as it is, and the immobilization induced hypercalcemia happens within 4 weeks, like 1 month. Okay, the onset of hypercalcemia due to immobilization is often insidious, and the presenting symptoms cannot be non-specific. No, the presenting symptom can be non-specific. Bisphosphonates inhibit osteoclastic bone resorption and are effective in treating hypercalcemia of immobilization and reducing the affected bone loss Okay, other option, like look at the C and F. Hypercalcemia in malignancy. Hypercalcemia in malignancy due to osteolytic metastasis, secretion of parathyroid hormone related peptide, and or increase 125 hydroxy vitamin D. So in hypercalcemia in malignancy, there is parathyroid hormone related peptide hormone is higher and increase 125 hydroxy vitamin D. But in here the two level is decreased actually. And mm, and in primary hyperparathyroidism, PTH level, this patient's PTH level is suppressed. So this which makes primary hyperparathyroidism unlikely. And acute rhabdomyolysis will cause hypocalcemia due to precipitation of calcium and phosphorus in the damaged muscle. So hypercalcemia can occur due to remobilization of calcium during diuretic or recovery phases of illness, often with concurrent hyperphosphatemia. However, these patients recovered from rhabdomyolysis several weeks before the onset of hypercalcemia. Yes. Mm. Okay, it's primary hyperaldosteronism. In primary hyperaldosteronism, aldo is high, renin is low, and aldosterone renin ratio is high. The causes are bilateral adrenal hyperplasia and adrenal adenoma. In secondary hyperaldosteronism, renin is high, aldo is high, renin is high, aldo is high, and the aldosterone renin ratio is near about normal. Secondary hyperaldosteronism due to renovascular hypertension, malignant hypertension, and renin secreting tumor. So, reninoma and renovascular hypertension, malignant hypertension for secondary hyperaldosteronism. In non-aldosterone mediated, where aldo is low, renin is low, the causes are Cushing syndrome, exogenous mineralocorticoid like fludrocortisone, and deoxycorticosterone excess. Deoxycorticosterone include deoxycorticosterone producing trauma. Okay, so this patient has low plasma renin, likely has secondary hypertension due to low plasma renin due to secondary hypertension, likely to primary hyperaldosteronism, which is typically caused by adrenal adenoma or benign adrenal hyperplasia. Primary hyperaldosteronism is characterized by autonomous aldosterone secretion that leads to increased intravascular volume and hypertension. Hypertension can cause headache if severe, and left ventricular hypertrophy S4 heart sound is prolonged. The elevated serum aldosterone causes suppressed plasma renin activity due to feedback inhibition of the renin angiotensin aldosterone system. Electrolyte abnormalities such as hypokalemia and metabolic alkalosis are present due to aldosterone mediated potassium and hydrogen secretion respectively. The condition of thiazide diuretics. The addition of thiazide diuretic chlorthalidone for the treatment of hypertension can substantially worsen these electrolyte abnormalities, as in this patient. Despite increased sodium absorption, extravascular volume load peripheral edema is rarely seen due to aldosterone skip. Aldosterone skip. Okay. Can you make me understand the aldosterone skip? I most of the time I mix up. Like the main function of aldosterone. Like aldosterone main function is aldosterone. Aldo is causing retained sodium and excrete potassium. So excreting. So potassium excretion that causes hypokalemia, hydrogen excretion that causes metabolic alkalosis, and sodium increased sodium reabsorption causing hypertension. Can you give me a minute? Yeah, there is a call. Wait, I'm coming. Okay. Aldo retain sodium and excrete potassium. So potassium excretion, that means high potassium. So when potassium and hydrogen are brothers, when there is high potassium, there is high hydrogen excretion. So high potassium excretion means hypokalemia, and high hydrogen excretion means metabolic alkalosis. And decrease sodium excretion, that means increase sodium reabsorption. That's why aldo is causing hypertension. More and more sodium reabsorption, and more, that's why there is hypertension. Okay. And when there is hypertension, there is decreased renin, decreased angiotensin. Okay. uh, what aldosterone escape means, like it limits edema by increasing the sodium excretion. Like when there is hypertension, there is increased blood volume, so increased renal blood flow, increased GFR, increased ANP. The ANP is the main thing for aldosterone escape. Like ANP actually excreting the sodium from our body. That's why there is low. That's why there is low edema. Like limits the edema. Okay. Is there anything else written in the Gemini? Okay. 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 You are watching Captain America, Brave. Okay. I have heard that movie is bogus. Okay. Yes, it's good actually. Low is low too. Maybe high. Look at the phosphorus. I don't know. Creatinine is normal. Magnesium. Okay, phosphorus is normal. Bit high. And if you do corrected calcium, what would be the value? Like 7.5 into plus 7.5 plus zero point 0.8 into 4 minus 2.2, isn't it? 0.8 into 1.8. Yes, yes. Mm, not really. Look, corrected calcium show it is normal calcium. The calcium level, corrected calcium is 8.94. Not minus. Is the plus, isn't it the plus? So it is normal. So corrected calcium is normal. Okay, you already found the reason why there is decreased calcium. Okay, just think in a simple way. Why I told you to do the math, because we are finding the corrected calcium, and in corrected calcium we found that the calcium level actually normal. So in corrected calcium, what are the other value we are looking at? Yes, yes, the albumin. So actually, due to low albumin, there is looks like hypocalcemia, but there is not actually hypocalcemia. So this question is bit tricky if you don't do the serum calcium level, like corrected calcium, what we have just seen in the other question. If we don't do it, then we are not able to find out the actual answer, because every anything can do a low calcium. Like if there is low pTH, if you see the option C, if there is primary hypoparathyroidism, like pTH is low, then calcium may be low. So it may be the answer. So got my point. So, we look at the option C first. Option C explanation. In hypoparathyroidism can cause hypocalcemia and is most commonly due to autoimmune destruction of the parathyroid gland or surgery or parathyroidectomy, like parathyroidectomy, thyroid or radical head or neck surgery or cancer. In addition to hypocalcemia, this patient would be expected to decrease PTH level and elevated serum phosphorus. But in here, serum phosphorus level is normal, so it is not hypoparathyroidism. Got my point? Okay. If we see the option E, pseudo hypoparathyroidism, it's a rare and characterized by PTH resistance in target organ. These patients have hypocalcemia and elevated phosphorus and high PTH level. Yes. And A and B, in vitamin D is formed in the skin or absorbed from the intestine. It is then hydrolyzed. It is then hydrolyzed in the liver, 25 hydroxylation to provide, 25 hydroxylation to produce physiologically inert 25 hydroxylation. The second step, 1 alpha hydroxylation occurs in the kidney to form physiologically active vitamin D. That means 125 hydroxycholecalciferol, which plays an active role in the calcium and phosphorus absorption from the intestine. Patient with chronic renal failure and unable Patient with chronic renal failure are unable to form 125 hydroxycholecalciferol, leading to hypocalcemia secondary to decreased intestinal absorption. However, these patients' normal creatinine makes This unlikely. Now the actual answer. Okay, approximately 40 to 45% of the total calcium is bound to albumin and other plasma protein. The remainder is transported in the remainder is transported in the blood as ionized calcium or complexed with phosphate or other ions. As a result, patients with hypoalbuminemia may have significant deficit in the total blood calcium. However, ionized plasma calcium, physiologically active form, is hormonally regulated and remains stable. Assessing the clinical significance of hypocalcemia is detected in the serum metabolic panel requires correction for the serum albumin concentration. The serum calcium concentration decreases zero point 0.8. The serum calcium concentration decreases 0.8 milligram per dl for every 1 gram per dl decrease in serum calcium or serum albumin. So the corrected corrected calcium can be calculated by using the formula. So corrected calcium measure total calcium plus zero point 0.8 into 4 minus serum albumin. The this patient with nephrotic range heavy proteinuria has a corrected calcium 8.94. The hypocalcemia is most likely due to hypoalbuminemia from nephrotic range proteinuria and is not clinically significant. Direct measurement of ionized calcium is performed in many clinical labs, but it requires special handling and may not be readily available. Got it? Okay. Uh, Detailed clinical management of hyperprolactinemia in premenopausal women. Detailed clinical evaluation rule out the secondary cause like pregnancy, then do the MRI of the pituitary gland. If it is asymptomatic, less than 10 millimeter microprolactinoma, no treatment is needed. As the patient is symptomatic, la- but this patient is symptomatic, even if the tumor size is only 6 millimeter, but this patient is symptomatic. So macroprolactinoma risk of presence of neurologic symptoms hypogonadism, and galacturia. This patient has galacturia amenorrhea. So first dopamine agonist, bromocriptine and cabergoline. If there is persistent hyperprolactinemia, persistent symptom, no decrease in tumor size, intolerance to medication, consider surgical resection. So this patient has a pituitary microadenoma less than 10 millimeter associated with galacturia and symptoms of low estrogen. Any mass in the pituitary gland can cause mild elevation in the prolactin due to disruption of the normal inhibitory dopaminergic regulation of prolactin secretion. However, significant elevation in the prolactin level, serum prolactin level more than 200 or a repeat level more than 100 suggests a prolactin secreting tumor. Prolactinoma, elevated prolactin levels suppress GnRH, LH, and estradiol, leading to oligomenorrhea in premenopausal women. Men and postmenopausal women often have normal early symptoms, are more likely to seek evaluation with a large tumor, more than 1 centimeter. Microadenoma causes mass effect, headache, visual field. Asymptomatic patient with an incidental finding of a microprolactinoma may be observed over time. Patients with macroprolactinoma or symptomatic tumors of any age, as in this patient, should be treated with dopaminergic agonist cabergoline bromocriptine, which can normalize the prolactin level and reduce the tumor size. Patients who fail to respond, who have a very large tumor more than 3 centimeters, should be referred to transphenidal resection. Marfan, yes, tall and his fingers long out, but look at the lip. What look at the lip. What uh, what what is the what picture says? Can you diagnose by seeing at the picture? Okay. Yes. Yes. He has mucosal neuroma, and if you know the mucosal neuroma, then it is easy to diagnose. One of those opposite gender disease, like you are woman and I am men. It is mucosal neuroma. So, like, think men 1 has 3P. Remember, men 1 has 3P: pituitary, pancreas, parathyroid. Men 2B, yes. 2A is parathyroid, thyroid pheochromocytoma, and 2B is thyroid pheochromocytoma and mucosal neuroma. And in mucosal neuroma, and there is like this type of Marfanoid habitus. Yes, yes. So there is numerous papule and nodule on the tongue. It is tongue, not lip. Okay, I thought that it's her lip. Okay, okay, okay. So this patient with known family history Marfanoid habitus, long arm and fingers, and mucosal neuroma, painless rubbery nodules, likely has men, multiple endocrine neoplasia type 2B. Men 2B is caused by a germline red mutation, is often identified via family history or genetic screening. Family members of a patient with a known germline red mutation should undergo genetic testing. The greatest threat to this patient, the greatest threat to this patient's life is to form medullary thyroid carcinoma. Medullary thyroid carcinoma is associated with men to be tends to occur at a very young age. Because of this risk, prophylactic thyroidectomy. Because of this risk, prophylactic thyroidectomy is performed in infancy age less than 1 year. Is in patients with known men to be. Half of the patients with men to be has pheochromocytoma, which needs to be evaluated with plasma fractionized metanephrine. Okay. Okay, it's a euthyroid 6 syndrome. Okay, look at this patient has infection, like he has pneumonia, and he has atrial fibrillation too. If somebody has infection like pneumonia, atrial fibrillation, anything, any infection, we should not do the thyroid function. Why? Because if you do the thyroid function, there will be, we can misinterpret, because his T3 is a bit low, but the other two like T4 and TSH is kind of normal. So it is euthyroid 6 syndrome or low T3 syndrome. Okay. So thyroid functions tests are often abnormal in patients with severe acute illness. Euthyroid 6 syndrome is a common pattern of thyroid function markers. Common pattern of thyroid function markers is markers often common thyroid common pattern of thyroid function markers often seen in hospitalized patients. A characteristic feature of euthyroid 6 syndrome is decreased peripheral conversion of T4 to T3 by 5 monoiodo, monodiiodinase factors that suppress conversion of T4 to T3. Factor that suppress the conversion of T4 to T3 is caloric deprivation, increased glucocorticoid and inflammatory sorry factor that suppress the conversion of T4 to T3 is caloric deprivation, increased glucocorticoid and inflammatory cytokine, tumor necrosis factor, interferon alpha level, and elevated free fatty acid level. Just as the inflammation leads to low T3 level, it suppresses the TSH. Although low T3 is initially may be on the only indication of euthyroid 6 syndrome, T4 and TSH level T4 and TSH level may also decrease. Okay, many experts believe that euthyroid 6 syndrome represents a mild, transient central hypothyroid state that functions to minimize the maladaptive catabolism in severe illness. In general, testing should be avoided in patients. Thyroid testing should be avoided in hospitalized patients unless a clear indication is present, as in these patients with an acute atrial fibrillation. Treatment of euthyroid 6 syndrome with exogenous thyroid hormone levothyroxine does not improve the outcome and is not indicated. During recovery, many patients experience modest transient increase in the TSH level, which may misinterpret as subclinical hypothyroidism. Uh, therefore, follow-up testing should be delayed until the patient return to baseline health. Okay. Hi. Normal phosphorus level is what? 4 to 5.5. Okay, and magnesium is 1.5 to 2. And he is on bisphosphonate. Bisphosphonate can cause, so he is on bisphosphonate. Bisphosphonate can cause hypercalcemia. Her normal. Okay, it may be like he look at the question. He is taking over the counter antacid. Over the counter antacid. So it may cause milk alkali syndrome. Antacid causes calcium carbonate. Yes, antacid causes calcium carbonate. Maybe. And other does not fit with this scenario. Sorry. Loop loop loses calcium. Loop loses calcium. And increased calcium maybe thiazide diuretics like hyperglycemia, lipidemia, uricemia, and calcemia. And, as far I remember, the mnemonic loop loses calcium, isn't it? So loop diuretics actually causes hypocalcemia, not hyper. Okay, I missed the calcium carbonate part. Yes. Okay. Okay, milk alkali syndrome. The patient has AKI as the patient has AKI associated with hypercalcemia and metabolic alkalosis. Associated with hypercalcemia and metabolic alkalosis, increased serum bicarbonate. In the light of recent use of antacid for in sorry in the light of recent use of over-the-counter antacid for bisphosphonate induced pill esophagitis. Bisphosphonate induced pill esophagitis. This patient has milk alkali syndrome. In milk alkali syndrome is due to excessive intake of calcium and absorbable alkali. Mm, Milk alkali syndrome is due to excessive intake of calcium and absorbable alkali, usually in the form of calcium carbonate antacid. Hypercalcemia Hypercalcemia in the milk alkali syndrome causes renal vasoconstriction and decreased GFR, renal vasoconstriction and decreased GFR, in addition to inhibition of the sodium potassium 2 chloride co-transporter due to activation of calcium sensing receptor in the thick ascending limb of loop of Henle. An impaired activity of the ADH leads to loss of sodium and free water. These this results in hypovolemia, AKI, as well as increased reabsorption of the bicarbonate, which is augmented by intake of alkali. Risk factors include CKD and concurrent use of Risk factor include CKD and concurrent use of thiazide diuretics, hydrochlorothiazide promote further. Risk factor include CKD and concurrent use of thiazide diuretics, which promote the volume of depletion and calcium retention. ACE inhibitor and NSAIDs, which decrease the glomerular filtration. Evaluation of milk alkali syndrome should include measurement of serum parathyroid hormone, which would be expected to be suppressed. Additional findings include hypophosphatemia due to intestinal binding of the phosphate by the calcium carbonate, and hypomagnesemia due to decreased renal reabsorption of the magnesium. Okay, okay. The patient has Graves' disease, presenting with hyperthyroidism, a goiter, and thyroid eye disease, proptosis, with extraocular movement, swelling of the periorbital tissue. Graves' disease causes hyperthyroidism due to activation of the TSH receptor on the thyroid follicular cell by thyrotropin receptor antibodies. TRAB ophthalmopathy in Graves' disease is due to effects of TRAB and activated T cell on the retroorbital fibroblast and adipocyte, causing cellular expansion and orbital inflammation. Treatment option for Graves disease include radioiodine therapy, antithyroid drug like methimazole, propylthiouracil, and thyroidectomy. However, radioiodine can induce radioiodine therapy can induce or worsen the thyroid eye disease, possibly due to an increase in TRAP level caused by leakage of thyroid antigen from the irradiated thyroid. Therefore, radioiodine intake is contraindicated in patients with moderate or severe thyroid eye disease. Okay, yes, complication of a Graves' disease treatment. Antithyroid drug like thianamides cause agranulocytosis. Methimazole is first trimester teratogen and cholestasis, and propylthiouracil causes hepatic failure and ANCA-associated vasculitis. Radioiodine ablation, permanent hypothyroidism, worsening ophthalmopathy, possible radiation adverse effect, and surgery. Permanent hypothyroidism, risk for recurrent laryngeal nerve damage, and risk for hyperparathyroidism. Next, keto, ketoacidosis. Maybe because glucose is high and bicarbonate is very low, like metabolic acidosis, and sodium is low too. Maybe, yes. Because in decay, what happens, even if the potassium level is normal, but there is a store of the potassium is low. So even if the potassium level is normal, in decay we actually give potassium until it is high, like more than 5.5, then we should stop giving potassium. Okay. So this patient hyperglycemia and anion metabolic acidosis decay likely due to undiagnosed type 1 diabetes mellitus infection upper respiratory tract fever cough in this patient infection frequently precipitates decay due to increased catecholamine cortisol and glucagon release presenting symptoms presenting symptoms presenting symptoms typically include polyuria polydipsia abdominal pain and fatigue. On examination, patients are often dehydrated and breathing normally osmolar respiration and to compensate for the metabolic acidosis. During decay, serum glucose exceeds the threshold for reabsorption by the kidney and resulting in glycosuria and osmotic diuresis. Sorry, I lost. Oh, okay. I was, I am, okay. During decay, sorry, yes, this is my nature. Even if I talking, I can fall asleep. Okay. During decay, serum glucose exceeds the threshold for reabsorption by the kidney and resulting in glycosuria and osmotic diuresis. This diuresis is accompanied by a net renal loss of potassium with depletion of the total body potassium store. However, serum potassium levels may be normal or elevated because acidemia and decreased insulin activity causes potassium shift to the extracellular fluid component. This word is very high. So potassium level may be normal as in this patient or elevated because of acidemia or decreased insulin activity. And decreased insulin activity causes potassium shift to the extracellular fluid component. So treatment involves gradual fluid repletion and insulin administration. Insulin prompts Insulin promotes potassium redistribution to the intercellular fluid compartment. Therefore, IV fluid are supplemented with potassium to prevent hypokalemia. Okay, actually, look, even if the potassium level you are seeing the normal, but the diuresis is accompanied by, look at the uh, depletion of the total body potassium store. So total body potassium store is actually depleted or low. The diuresis is accompanied by net renal loss of potassium with depletion of the uh, total body potassium store. So body potassium store is losing. That's why there is the body potassium, what your body's stored potassium is releasing into the blood. That's why blood potassium is high, but total body potassium is low. So they are talking about total body potassium. You got my point. uh, you have seen the picture like the intracellular. Okay, look, before insulin treatment, potassium is from the extracellular compartment, from the extracellular potassium from the intracellular, like potassium from with the cell. Potassium is going outside the cell. So outside the cell means within the blood, like potassium is coming into the blood, and in the cell there is no potassium before treatment, and after treatment potassium is entering into the cell. So as potassium is entering into the cell, so total stored potassium, the potassium stored in the cell, so stored potassium is again regaining. So stored potassium is now normalized when you are giving insulin or when you are supplementing the potassium. Got my point? I don't know you have understand or not. They are not talking about the blood potassium level. Blood potassium is raised because from the cell potassium is coming into the blood, so blood potassium is raised, but the stored, but the cell potassium is low. They are talking about cell potassium. If in this system they will say hyperkalemia, so it is normal. So it may be the answer. There may be hyperkalemia because the stored potassium is coming into the blood, so there may be hyperkalemia. Okay, you have taken your breakfast. Okay, okay, no, first do up to 20 question, then we take a break. Okay, okay, it's congenital hypothyroidism. This 4-month-old patient who is unable to lift her head has hypotonia, a worrisome finding in young infants, and that may be suggestive of a neuromuscular genetic disorder. That may be suggestive of neuromuscular or genetic disorder, but is more commonly due to infectious or metabolic condition. This patient has bradycardia, elevated frontal allele, constipation, Characteristics findings of congenital hypothyroidism. Patients are typically asymptomatic at birth due to transplacental transfer of maternal T4, and they develop symptoms as levels wane over weeks to months. Congenital hypothyroidism is due to thyroid dysgenesis, leads to hypometabolic state leading characterized by lethargy, less activity, uh, feeding problem, poor weight gain, constipation, bradycardia as seen in this patient because of skeletal muscle has because skeletal muscle is a highly metabolic tissue. Skeletal muscle is a highly metabolic tissue that requires thyroid hormone signaling for contractile function. Patients develop diffuse myopathy with hypotonia and weakness. T4 also regulates the generation of mucopolysaccharide, which accumulate in the subcutaneous tissue in the hypothyroidism, causing myxomatous skin changes, macroglosia, protruberant abdomen, and umbilical hernia. Finally, enlarged frontally with delayed closure are typical because thyroid hormone promotes bone growth and maturation. Lab evaluation shows increased TSH and decreased T4. Prompt treatment with levothyroxine reduces the risk of neurologic deficits and developmental delay. Constipation and abdominal pain. Uh, Sorry, yes, hypercalcemia. He is not on bisphosphonate. Instead of bisphosphonate, he choose taking oral calcium like calcium carbonate or other calcium containing. He how he will take more calcium like the requirement, like per day calcium requirement near about 1000. If somebody takes more than 2000 3000, and then his calcium carbonate load will be increased and thus causing the what milk alkali syndrome. Vitamin A increase, like high vitamin A causing vitamin A toxicity causing pseudotumor cerebri, like idiopathic intracranial hypertension, where there is fundoscopic finding. You will find papilloedema, and lumbar puncture show high pressure. There is no such kind of feature. Vitamin A toxicity, if you want for vitamin A toxicity, it may be pseudotumor cerebri. It does not cause hypercalcemia, as far I remember. Okay. Okay, this patient, typical symptoms of hypercalcemia, including abdominal pain, constipation, polydipsia. In the light of initiation of the over-the-counter supplement for osteoporosis 3 months ago, her symptoms are likely due to milk alkali syndrome. Milk alkali syndrome is caused by excessive intake of calcium and absorbable alkali calcium carbonate preparations used in patients with osteoporosis. The resulting hypercalcemia causes renal vasoconstriction and decreased GFR. In addition, inhibition of the sodium potassium 2 chloride co-transporter due to activation of the calcium sensing receptor in the thick ascending limb of lobe of Henle and impaired ADH hormone leads to loss of sodium and free water. This results in hypovolemia and increase uh, increase reabsorption of the bicarbonate, augmented by the increased intake of the alkali. Medication that raise the risk of milk alkali syndrome, like thiazide diuretics. This patient is on thiazide. Yes, okay, I haven't seen that. Okay, this patient is on hydrochlorothiazide, and this patient is on thiazide diuretics. Where I lost. Okay, okay, medication that can raise the milk alkali syndrome include thiazide diuretics, AC inhibitor, ARBs, NSAIDs. In addition to hypercalcemia, metabolic findings of milk alkali syndrome is hypophosphatemia, hypomagnesemia, metabolic alkalosis, and AKI. Parathyroid hormone levels are suppressed. Okay, okay, let's take a break.